want to thank you and thank the organization for inviting me and to give me the opportunity to share with you our experience about the surgical management of the complication after LVAD implantation in La Pitié-Salpêtrière in Paris. I have a few disclosures like all the surgeons involved in MCS, I think. First of all, we say that in the other presentation, with the time, with the years, we improve our result in terms of survival with LVAD. For sure, in the last Intermax report, you can see on this slide, the survival rate is at 1 year is about 80%. 80% is very nice because it's quite similar to the survival rate after an heart transplantation. So it's a very, very nice result. But on the other end, in terms of adverse event, there is no improvement or very few improvement. As you can see, at 2 years, 80% of the patient develop a serious adverse event. Serious adverse event with infection, bleeding, device malfunction, stroke, or death. You can say, okay, it's on the Intermax report with a lot of patients, with a lot of different centers, but what about the last device and in experience or experts teams? Well, you can see on the roadmap study, by example, which was published the last year in the JACC, and we did a comparison between optimal medical management and LVAD implantation for patients in heart failure, and they report the result at 2 years. You can see exactly the same thing. You can see that we improve the result in terms of survival with 80% of survival at 1 year. We improve the clinical status of the patient, improving the functional things. And what is probably also the most important part, we improve the quality of life for this patient. We improve the survival, we improve the clinical status of the patient on the quality of life, but not the adverse event. It was exactly the same thing that in the Intermax report. You can see that we have a high rate of adverse event, and I summarize for you on this table this complication rate. For thrombosis, 12% at 1 year, at 2 years. Stroke, 12%, more than 50% for bleeding, sepsis and driveline, 20%. Right ventricle failure, 10%, but you will see in other publication it's higher, and arrhythmia, 22%. So it's a big limitation of this technique today. It's still a big limitation, and it leads to 65% of rehospitalization. So today, this is a big limitation. But you can say, okay, in roadmap, but what about momentum 3? Momentum 3 with ArtMed 3, it's quite the same result, in fact. You can see the complication rate on this table. The only difference is maybe about the thrombosis, the pump thrombosis. We have a trend to no thrombosis in this publication, but it's just about 150 VAD implantation in selected patients, in experts teams. So I think it's necessary to have more patients and more experience to have a very robust conclusion about that. So today, even if we improve the result in terms of survival, in terms of quality of life, we have still a lot of adverse events. And when we consider LVAD as a bridge to transplantation, as a bridge to recovery, or as a destination therapy, I think it's still a dangerous bridge because we are quite in the fog, and the fog is all the adverse events which could happen when you are under this support. First of all, the bleeding. The bleeding concerns a lot of patients. 50 to 85% of the patients in the literature at 2 years of circulatory support, and probably because of the non-physiological flow, because of the shear stress of hemolysis, because also you develop under VAD support an accurate von Willebrand disease, also because you have a limited pulsatility and because it's necessary to have antiplatelet and anticoagulation, you have a physiological disturbing for the blood, for hemostasis, for sure, but also for vessel, by example, with neoangiodysplasia. And this is why we can explain that VAD is associated with cerebral event, hemorrhagic cerebral event, 0.13 events per year and per patient. And for the GI bleeding, 0.5 events per patient year. So when you are in front of this complication, you want to decrease the anticoagulation for your patient, for sure, but you are in front of the other complication, which was very well described by the last speaker, the stroke. The stroke happens in 10% of the patient at 2 years of circulatory support in the literature, and you can see in the Intermax report at 3 years the incidence, the rate of stroke is 20%. Another limitation of the device of the VAD support is the infection. 30 to 50% of the patient will develop an infectious complication, pneumopathy, infection of the urinary tractus, by example, but also infection of the device by itself, infection also of the driveline, and you can see that the infection of the drivelines concern 20% of the patient at 1 year of support. So it's an important limitation, but it will be described by another speaker, so I won't speak of that a lot. Just to tell you that medical management could be efficient for sure with antibiotics, but it's not sufficient. And what is the more efficient technique in this, in front of this complication is the surgery with drainage, excision, sometimes muscle flap or vacuum therapy, and also pump exchange or heart transplantation when you have no other choice. And infection, it's also the first step to another complication, which is the pump thrombosis, very well described by the last speaker, and which happens for 10% of the patient at 2 years in the literature, with several risk factors related to the patient, infection, by example, coagulopathy or other things like that, but also related to the device by outflow graft kinking, outflow graft compression, inflow malposition also, or because of problem of management of the patient with an inadequate anticoagulation after bleeding, by example, when you have to decrease the anticoagulation, also when you reduce the speed of the device. And when you are in front of that, when you suspect a pump thrombosis, to make the diagnosis, what is very important is the imaging. Why? Because it's important to have a CT scan, echocardiography, catheterization to localize the problem, to localize the thrombosis, because the treatment could be very different. This is what was described by the last speaker, because for sure medical therapy could be efficient with anticoagulation, with things like that, but surgery is probably the most efficient strategy to manage this complication, correcting the complication, but also by pump exchange or heart transplantation. And it's very important to identify the problem site because it will define the surgical technique. And the surgical technique could be totally different between a pump exchange, between a correction of the kinking, of the compression or things like that. And so you will change totally the surgical approach. And what is important to consider is that even if you have to change the pump, it's not necessary to redo a sternotomy. It's better to avoid to do that for a lot of reasons, for bleeding, by example. And a thoracotomy could be very, very efficient. This is why it's very important to localize the problem site when you want to manage surgically this kind of complication. And last but not least, the right ventricle failure is today, I think, one of the main limitations of the VAD. It's something which happened in the literature for 30% of the patient, but in fact it depends of a lot of things. It depends of the selection of the patient, it depends of the teams, and probably it's underreported in the literature. But you can see that when you have no right ventricle failure, the survival rate is 80%. Okay, this is very well known. But if you have a right ventricle failure, you can forget this nice result, and the result in terms of survival is just 50 to 60% in the literature, because with the right ventricle failure, you will also increase the adverse event rate. You will increase the multi-organ failure, increase the sepsis, increase bleeding, cardiopulmonary failure. So today, it's still an important limitation. This is why it's important to answer to this question. Is it possible, is this right ventricle failure after LVAD reversible? Interesting question, but I have no answer for you. And in the literature, it's not so easy. You can see in this interesting publication from the Berlin team, from Michael Dundell and Roland Hetzer, they tried to explain the physiopathology of the right failure and to define an algorithm considering pressure of the right ventricle, pressure in the right atrium, tricuspid regurgitation, and also some echographic parameters to define 3 categories of patient. Patient for whom LVAD implantation will be successful. Patient for whom it's not possible because the right ventricular failure is irreversible, so it's necessary to consider the patient for biventricular support or a total artificial heart. And in the middle, and this is the more boring situation, a patient for whom LVAD is possible but with a temporary right ventricle support. But what about patient under ECMO support? When you have a patient in a bridge-to-bridge strategy, today we have no way to assess the right ventricle function, and it's still a limitation to choose the good device for this patient. Probably, maybe, Impella added to the ECMO could be interesting because it's a percutaneous LVAD, so you can try to test the right ventricle under Impella support. But with the LVAD implantation, you will, for sure, decrease the right ventricle afterload, but you will also increase the right ventricle preload. And what is probably the most important problem, you will decrease the right ventricle contractility because of change in the septal curvature. And this is why you will provoke, the LVAD implantation will provoke by itself a right ventricle failure. But when we speak of right ventricle failure, we speak of several things. There is RVF and RVF, like there is fire and fire, and the management could be very different. You can have a medical management, for sure, decreasing the speed of the pump. You can also use inotropes, NO, prudent filling, for sure, but sometimes it's not sufficient and it's necessary to add a right ventricle support. For that, ECMO could be helpful. In emergency, it could be a good approach because it's easy to set up. At the bedside of the patient, in few minutes, you will unload the right ventricle for sure, but also you will increase the left ventricle afterload and the LVAD afterload. So you increase the risk of LVAD thrombosis. So in emergency, it's interesting, but I think it's better to avoid to do that for a midterm support. For a midterm support, it's better to use an elective right ventricle support, and for that several things are described in the literature. What is very well known today is to use such a cannulation with a cannulation of the right atrium and reinjection with an ECMO in the pulmonary artery. So to remove this device after this right ventricle support, it's necessary to go in the operating room to remove the cannula. But you can also, and this is what is described in this publication from a German team, and this is also what we do sometimes in La Pitié, you can also use some daquantum graft on the right atrium, on the pulmonary artery. And when you want to remove this device, this right ventricle support, you can cut the daquantum graft at the skin, avoiding a new sternotomy for this patient. You can also use, and this is what we do in La Pitié very often, a full percutaneous approach with a pigtail in the pulmonary artery, and you put a guide wire in this pigtail, and after you can perform like that selective cannulation of the pulmonary artery to provide a full percutaneous elective right ventricle support. But for that, it's necessary to be sure that all the perforation of your cannula are up to the pulmonary valve. You can also use the Impella RP, which seems to be very efficient. We have no experience with that in La Pitié because La Pitié is in France, and France is a poor country with no petrol. We have no petrol, but we have some ideas, but sometimes it's not sufficient. And we hope we will use this device in a few months because I think it's very, very interesting to use this percutaneous approach to support the right ventricle. But the right ventricle support, elective right ventricle support, is very efficient for sure, but it's not a magic weapon. And it's not possible to imagine that you can change a biventricular patient into a monoventricular patient. In this situation, it's better to choose a biventricular support or a total artificial heart. And to conclude, today, LVAD improve its result in terms of survival, in terms of quality of life for sure, but not in terms of adverse events. And it's still a limitation of this device for sure, with bleeding, stroke, infection, thrombosis, and right ventricle failure. And if we want to improve this result, it's necessary probably to improve the patient selection, to improve the biocompatibility, maybe also to improve the pulsatility of new device, and also to improve the power supply. Thank you for your attention.